Thank you for inviting me to speak today. I have no disclosures to discuss, so let's talk about blood flow restriction rehabilitation. So I work for university hospitals. This is my clinic. Actually, the clinic is in the back corner, but I work within a sports performance facility west of here in a city called Avon, Ohio, at a place called T3 Performance. And I work mainly with high school, collegiate, and professional athletes. And we spend a lot of time doing sports specific and return to sport type activity on the field, but in the back where you can not exactly see over through here is where we do a lot of strength training. And strength training, similar to what Dr. Kanitas was saying before, we typically as physical therapists tend to give people TheraBands and small sort of low to things that from a weight standpoint are very low that really don't achieve the strength training measures that we're trying to do. And what we know is based on the American College of Sports Medicine, to grow a muscle, to make it stronger or larger, it needs to be loaded at 70% or greater of a 1 rep max. And so we spend a lot of time doing heavy lifting in a lot of our athletes because that's what they need for performance and for injury prevention. But the problem is most of the folks that we see are injured during play and then also post-surgical. And so that can be a problem. And these people need to be strong too. So what we've been utilizing more so in the clinic is what's called blood flow restriction rehabilitation. And that's been discussed slightly in a few other the talks today with Dr. Moskovsky and Dr. Carnes. But what we do is we apply a tourniquet to either the proximal arm or the proximal thigh, and we inflate that to essentially reduce arterial inflow, but to occlude venous outflow completely. So we're trying to pull a lot of blood within the limb. And then we're going to load them at 20 to 30% of 1 rep max. And that has been shown to increase strength and hypertrophy at these lower levels. So in theory or hypothetically, how does this work? Well, when you have a tourniquet on a working limb, and you're exercising, it's an anaerobic state and you're starting to produce a lot of lactate. And when you have lactate, there's a cascade of effects that are occurring. And what happens initially is these muscles that are working start to become very fatigued and they need to recruit other muscle fibers nearby. So you have an increase in EMG activity. You also get a large growth hormone release, and that's not necessarily, growth hormone doesn't cause muscles to grow. It actually has more of a healing property to it, but it does stimulate increase in IGF-1 and satellite cells, and those do become muscle fibers and can help a muscle grow as well. And we also have an increase in mTORC1, which is vital in increasing muscle protein synthesis, so in muscle growth. And then lastly, it's been stated that it can downregulate myostatin. And this is an interesting animal called the Belgian blue cow, and it is a myostatin resistant cow. Myostatin is thought to be sort of like the bouncer that allows you to get muscles bigger or not. And if you can downregulate myostatin, you can grow muscle easier. And in this case, this is a myostatin resistant animal. And so I've never had a Belgian blue steak, so I can't tell you how that tastes, but I assume this is a very strong animal based on just the looks alone. So what about is going on? It's very interesting right now what's going on in BFR. In the literature alone, if you just search in PubMed blood flow restriction rehabilitation, you get 611 results. And nearly 300 of those papers have been published since 2019. So it's very, very hot right now. There's also over 100 clinical trials going. So there's a lot of research going on in this field. There's a lot happening. And when we look, there's a good number, I think somewhere in the realm between 30 and 50 systematic reviews, meta-analyses. And I give you 4 examples here, and we typically refer to these as our top shelf in the pyramid of evidence. It's the top of the pyramid, or as we collectively call the top shelf liquor of our evidence. But in these 4 studies that we have here, essentially it's looking at what happens when you use blood flow restriction and strength training compared with low load training or with heavy load training. And we see it in regular healthy individuals, in people that are undergoing musculoskeletal rehabilitation and so on. And what we find is if you load someone up with low load, low load with blood flow restriction, and high load, there's a significant increase in strength and hypertrophy in the BFR low load group and in the heavy load group, but you don't see that significant change in the low load group. And so this is what makes it really nice from our standpoint of bridging the gap in somebody who's injured or post-surgical to gain strength earlier on and get them back to the field of play faster, and get them to lifting heavier to gain the strength that they can faster than if we didn't have it. And then the question becomes, is it safe? And yes, collectively and generally, it is accepted as a safe modality to utilize in therapy. And the common questions are, what about DVTs and pulmonary embolisms? And the incidence of these are very low. And in and of itself, it's not an independent risk factor for clotting. We avoid utilization in folks who have a recent history of clot, but for the majority of folks that we're utilizing this on, it's not a risk factor. What about muscle damage? When we lift heavily, we know that can really tear down muscle itself and can cause problems in very extreme ways. But the literature itself, it suggests that there's no muscle damage that's occurring when we're doing BFR. What about hemodynamics? Blood pressure, heart rate, and rate pressure product all elevate similarly to if you're lifting in a high load environment or condition. And what that is thought to be is saying, and that's with age, it's the same across all ages and types of people. And so they say this is a suitable modality to utilize in all conditions, including in an older population. The one concern that we do have is this exercise pressure reflex, and that comes into our cardiovascular or peripheral vascular disease compromised folks. And this is where we might choose to avoid use. And then from a nerve conduction standpoint, we know that this is in the form of dysthesias or numbness with use of the tourniquet. And so the incidence of these things are low, and usually if the complaints, they're very minor. And when you remove the cuff, they go away fairly quickly. But we also know methods matter in our application. So we tend to put it in a proximal thigh or proximal arm. And in this case, a person is using an occlusive device and they're putting it on their, their proximal tibia and over the fibula there where the common peroneal nerve lives, which could probably be a problematic situation. And so we try to avoid placement in a superficial nerve location. So who benefits from this? So we would think athletes would be a really great option, which we do think that's the case. But a lot of this research has been done on sarcopenic populations, so older individuals with loss of muscle mass. There's studies where they put a tourniquet on bilateral lower extremities. They walk on a treadmill for a given amount of time, and that increases cross-sectional area of the thigh muscles, increases strength of the legs, and then they increase in walking tests. We utilize it a lot in our clinic for post-surgical folks and after injury. And I like it a lot in some of the fractures or stress fractures, because there's been a lot of thought that you can increase angiogenesis and increase healing times with fractures. But we specifically use it a lot with our ACL reconstruction folks, meniscectomies and hip scopes. So here's some examples of use in the clinic. We also like to utilize, if you can't use, it gets its most benefit if you're performing blood flow restriction rehab along with some load. If they can't tolerate load, then we will use electric stim a lot of times. Like you can see in this photo here, this young man is very near out of his ACL, and we could do quad sets, right? Quad sets are fine, but the problem is a lot of times in our meniscal repair folks, they can't be weight bearing, and we're concerned about atrophy. And well, there's been a few studies that have looked at it, utilization of BFR to decrease atrophy of these muscles. And so what we tend to do is we connect them to an MES, and we do Russian stimulation with the cuff intact or in place. And then they get a little bit more bang for the buck with the exercise. And then in the second picture, we're sitting and we're doing a traditional Russian stimulation where he's doing an isometric knee extension contraction into the belt. You can see the strap around his thigh there. And he's being stimulated per the protocols of the Russian stim, but we're also utilizing the BFR. And again, we're trying to stave off loss of quadriceps in this performance, which is usually what we're digging people out of the hole for in the long term. And so if we can keep more of the quad longer, even better. And then when we progress next, it would be to body weight type exercises and loaded exercises. So you can see in the video here, this young lady a few weeks out of her ACL and a meniscal repair where she could start weight bearing again. And she actually has, it's hard to see, she has a laser that's attached to her thigh that's helping her with her motor control as she's doing a single leg squat with BFR. And then we would move on to, loaded step downs or long arc quads, even, knee extension, leg press, or any other loaded type exercises. And again, we're aiming for that 20 to 30% of a 1 rep max to really increase hypertrophy and strength in a muscle. This is a fun picture. This is an NFL player who had an ACL reconstruction, and they were a few weeks out, or I think they were a few months out, and they were coming in to have continued therapy. And you can see they say the effects can happen as quick as 2 to 3 weeks. Usually it's more like 10, but this person was able to gain some hypertrophy very rapidly with 4 weeks of BFR. One study, this is a sort of a very small study of 7 folks that then became a clinical trial that they're wrapping up now. And it was very interesting to the orthopedic surgeons because it showed they did, instead of just looking at loss of bone or muscle mass, they started to look at bone density, because what they knew is when you do an ACL reconstruction, you get an osteopenic effect that occurs. And that could potentially interfere with how well that graft stays in place. They looked at I think it was 14 folks, and they did 7 and 7, and they looked at their bone density. And what they found is that a group that did BFR and as a part of their rehab, they had less loss of bone with performance compared to the control group. And so that became a bigger study. And so that's a really good thing to know when we're trying to incorporate the new graft into the system. And then one other area of research that's really been going on more so lately is what's called Bfr Induced Hypoalgesia. And this has been looked at more closely in our anterior knee pain or our patellofemoral pain type patients. In one of the studies they looked at, they would have the patients come in prior to the therapy session, and they would do 1 BFR knee extension exercise. And what they found was that their resting pain levels from before that, and then they would do the rest of their entire physical therapy session as normal, and then they would look at their pain during and after. What they found was there's a significant decrease in their pain reported with performance of the rest of the physical therapy session after they did that single bout of blood flow restricted exercise. So we utilize this sometimes in our anterior knee pain patients as an adjunct to have them tolerate exercise more. And that's really interesting that they're getting this decrease in pain. And there's several mechanisms that are reported to be responsible for that, which is either the conditioned pain modulation, which pain inhibits pain. They're doing more exercise, the cuff or the tourniquet itself, maybe with the pressure that's associated could, or the inhibition of nociceptive pathways via endogenous substances or hypoxia. Short and sweet. Is there any questions?
What's the time that you use this for? A half an hour, or
and
at what level?
Some people will say a half hour. So you level from a pressure standpoint. Typically in a lower extremity, we use 80% of what we call arterial occlusion pressure. And so there's a couple ways of measuring that. You can do it via certain machines have a Doppler or a Doppler-like effect inside that can measure how much pressure it requires to completely occlude. And other times you just use a Doppler device and you can do it yourself. So in the upper extremity, it's 50% occlusion typically, and in the lower it's 80%. And then we can undergo anywhere between 2 or 4 exercises. And a lot of times strength exercises take place over the course of maybe 6 to 8 minutes at a time. So it's occluded at whatever their pressure is. It's personal. It's dependent on the size of the limb, size of the person, their blood pressure, a couple other things. But typically they exercise somewhere between 6 or 8 minutes, rest for a very brief period, and then go on to the next exercise. And usually what the most reported scheme is, they do 30 repetitions, they rest for 30 seconds, and then they do 3 sets of 15 repetitions and to build up the lactate, and then they deflate the cuff in between the next exercise. Mm-hmm.
Is there any utility of using this in uninjured athletes?
Yes. And so there has been research in a few different, and this is tough because now you're starting to go down like a big wormhole, but there's use in what's called ischemic preconditioning and ischemic postconditioning, where you utilize it passively. And it's been shown to have a protective effect. And this was sort of taken from a lot of the cardiovascular type research, but people will use that prior to almost have a protective effect, so they won't have as much pain or soreness after like heavy bouts of exercise. It can also be used as a recovery adjunct afterwards. There's a few studies on that, but some folks will use it as a part of a heavy load training. They'll do a lot of heavier loading, and then they use this in the end as another way to sort of get the same effects of heavy load exercise, but maybe not with the same amount of muscle damage. So as more of like a training adjunct. And that has been looked at.
And what's your experience or thoughts about the commercially available elastic bands or rubber bands and straps that are to accomplish the same goal?
So we have this discussion about tourniquet use and what's appropriate. And we look at sort of like field tourniquets that they would use in like war and the things that come along with that. And a lot of the time, the width of the tourniquet makes it a little bit more comfortable. The ones that are commercially available are usually thinner. And when you place it, it's hard to tell how much pressure actually is giving you the effect you're looking for. There's some subjective reports of it should be a 7 or an 8 out of 10 tightness, whatever that means to someone. And they can be a little bit tighter. I think the problem is how quickly it could be removed from a safety standpoint. I think the risk of injury is probably low, but probably not zero. And so I like to have something that's a little more specific. People will do all sorts of things. In a previous talk, I have, TheraBands and ACE wraps and showing all these pictures of people doing different things in the gym. And I tell people it's one thing when they're at the gym doing their own thing. But when I'm in a rehab setting specifically, I want something that I can control and make it as a more objective and specific to what we know is going to work more so. So I know I see people at the gyms utilizing these different types of devices, though I don't know if you can control the exact amount of pressure to the extent that you might want to. Not to say it wouldn't get the same effect. It just depends. There's reports between 40 and 80% of limb occlusion pressure providing an added benefit. So you have a little bit of window of room to potentially get it right, but it's a little bit harder to dial in those cases. Thank you.
Here.